Hello, everybody, and welcome to today's Health for the World lecture on contrast-enhanced mammography. I am Juan Guerrero Calderon, breast imaging fellow at Emory University, and I'm very excited to present Dr. Kathryn Zamora as our speaker today. Dr. Zamora is an associate professor of the breast imaging section at the University of Alabama at Birmingham, UAB, where she serves as the program director of the Breast Imaging Fellowship. Dr. Zamora received her MD and MPH from Tulane University School of Medicine in New Orleans. She completed an internship in internal medicine and residency training in diagnostic radiology at Ochsner Clinic Foundation in New Orleans. Following residency, Dr. Zamora pursued additional training with an accredited fellowship in pediatric imaging at Miami Children's Hospital and a second fellowship in women's imaging at Louisiana State University in New Orleans. Dr. Zamora has a special interest in resident education, and I happily and I'm very proud to have trained under Dr. Zamora during my residency. So I will leave all of you with this great lecture on contrast mammography with Dr. Zamora.
Thank you very much for that wonderful introduction. I'm very excited to be presenting this lecture to everyone on contrast enhanced mammography. So we'll go ahead and get started. Disclosures, I have none. The learning objectives for this lecture today are going to be to understand the advantages and disadvantages of contrast enhanced mammography, sometimes abbreviated CEM or CESM for contrast enhanced spectral mammography. Want to understand the imaging technique, know the potential and approved indications, particularly this is going to be in the United States, recognize appearances of common benign and malignant findings, and understand potential pitfalls and diagnostic challenges, including some common artifacts. A little background on mammography and digital breast tomosynthesis. We do know that from randomized controlled trials and observational studies that screening mammography reduces mortality from breast cancer. However, we also know that the sensitivity of mammography and tomosynthesis is limited by tissue density. Tomosynthesis has improved cancer detection in dense breast, but it is still a limiting factor. Here we have some images of the 4 categories in BI-RADS of breast density over starting on the left of the image. You can see a predominantly fatty breast, and then advancing to the scattered fibroglandular densities, to heterogeneously dense, and to extremely dense breast. If you slice it down in the middle, the 2 to the left of the screen are considered not dense, and the 2 to the right of the screen are considered dense breast, heterogeneously dense, and extremely dense. And that is about 50% of our population here in the United States are considered to have dense breast. And the problem with dense breast tissue is the breast tissue is white, and cancer is normally white as well. And so it can obscure small breast cancers. As you can see here in this extremely dense breast, if there was a small cancer here, it would be obscured by that overlying breast tissue. So that decreases the sensitivity. So as the breast is more dense, or the sensitivity decreases. MRI examinations. MRI is an exam that we can use that is not limited by breast density, which is wonderful. However, it does have a lot of disadvantages compared to mammography. One, it is extremely more expensive. Not only the machine itself, but you have to have a special room for it, and it entails a lot of additional costs, including the machine. It's a more time-consuming examination for the patient. Usually takes between 30 minutes to 45 minutes. It cannot be performed in patients that have metallic implanted devices, typically that aren't MRI compatible. It is less patient friendly. The patient's usually laying on their stomach and within a small gantry, which sometimes can be uncomfortable. And additionally, it leads to more false positive examinations. Contrast enhanced mammography is also not limited by breast density, which makes it a good examination in that respect. It is significantly less expensive than MRI examination. It doesn't require an MRI machine. It is an additional add-on to a mammography unit. It is less time consuming than MRI examination. Contrast exams are usually take between 2 to 10 minutes but about 10 minutes to complete. It's more patient friendly. Additionally, it's been proven to have a similar sensitivity to MRI examination. A meta-analysis of comparing 13 studies demonstrated a 97% sensitivity for breast cancer detection in both contrast-enhanced mammography and MRI examination. Also in this meta-analysis, contrast-enhanced mammography showed a higher specificity, 66% compared to 52%. Reviewing some of the advantages and disadvantages. The advantages we did talk about a little bit already. It's fast acquisition time, about 10 minutes, less expensive than MRI examinations. It may be utilized in locations where MRI is not available, and that's important for many countries here. It may be utilized when there's contraindications for MRI for the patient. Additional advantages, it's more sensitive and specific than mammography for the detection of breast cancer since it is a contrast-enhanced examination. And also, as we discussed, it has a similar sensitivity for breast cancer detection as MRI, but fewer false positives. Disadvantages of contrast-enhanced mammography. It does have limited assessment of the posterior tissues when compared to breast MRI examination. It's difficult to evaluate if there's tumor involvement of the chest wall. We don't really view the internal mammary chain lymph nodes or the upper axillary level 2 and level 3 nodes very well. So that is a limiting factor. And one of the largest disadvantages currently is the lack of biopsy capability. So we can perform these contrast-enhanced images and find areas of concern, but then we don't have a way to target them using the same contrast enhancement. Typically, we either need to move them to MRI or look for it using ultrasound or mammographic landmarks. Hopefully, this capability will be coming out at some point in the near future. Additional contraindications are those to iodinated contrast. So if they've had a severe contrast reaction or they have abnormal renal function, that we cannot use this examination. And personnel requirements, because it does use contrast, a radiologist or other licensed physician typically needs to be present to evaluate for potential contrast reactions. So just to make sure everyone's kind of paying attention, first question, we'll have 4 here. Does breast density limit the sensitivity of contrast-enhanced mammography? And the answer is no. Okay, so we'll discuss technique. Really important that the appropriate technique is utilized in this imaging examination. As for regular mammography, technique is important, same with contrast exams. So first, we want to screen for contrast and see if they are able to receive it. One, we want to assess for allergies and renal function. Here at our institution, we will not perform this examination if the GFR is less than 30 because we do not want to give them the iodinated contrast. Also, if they've had a history of anaphylaxis, we will not perform this examination. There are sometimes, if they've had a mild reaction, such as itching to iodinated contrast, we may pre-medicate using our regimen prior to the examination. The dose that we give is usually 1.5 milliliters per kilogram of low osmolar iodinated contrast, and we administer that via IV power injector at a rate of 2 to 3 milliliters per second. Our maximum dose is 150 milligrams. We obtain bilateral low and high energy images in the CC and MLO projections for each breast. The images should be acquired between 2 to 5 minutes following contrast injection. So you want to wait 2 minutes prior to compressing the breast and imaging for that contrast to be taken up into the tissues and move out of the vasculature. The low and high energy images are acquired during a single compression, and that's important because that does decrease motion. The low energy parameters are the same as standard full field digital mammography. It uses the same filters and the KVP of between 25 and 30. The high energy parameters are different, and they use a copper filter and a higher KVP between 45 and 49, which is optimized to the K edge of iodine. Here's a schematic on how we would acquire our standard contrast enhanced mammogram. First, we would inject the patient via IV. We wait 2 minutes. Then we place the patient in compression for the first view that we are going to obtain. And this is going to be the right CC view here. And in that single compression, we obtain our low and high energy images. We reposition the patient, compress again, obtain the low and high energy images for the left CC, reposition, compress, obtain the low and high energy images for the left MLO, reposition, compress, low and high energies for the right MLO. And then this all should be accomplished within a 10-minute time frame following the injection point. The order in which you take the images actually is completely up to you. A lot of places will start with the breast that seems to be the problem. So if they present with a palpable abnormality, they'll start with the breast that has the area of concern to make sure that they image that adequately within the time frame. But there's no data that says one way is better than the other. Again, the recombined images are produced by canceling out the background tissue, and that's what we use in our interpretation. So the low energy images, which are the same as full field digital mammography, and the recombined images are what we use in our interpretation. And the high energy images are not interpreted. And in our institution, they're not even sent to the PAC system. There have been studies that show that the low energy images are equal or non-inferior to standard digital mammography. Here's just a single example of a left CC view here. You can see the low energy image here on the left looks just like a standard CC mammogram, and then the recombined image has the kind of subtraction appearance where you see a little bit of contrast in the vasculature, no suspicious enhancement. This was a negative examination. Question 2. At what time should you begin to acquire images following contrast administration? A, at the same time as injection, B, immediately following injection, or C, 2 minutes following injection? And the answer is 2 minutes following injection. You want to wait for that contrast to get out of the vasculature before you compress that breast so it doesn't get stuck in there and it can go into the tissues. Indications for contrast enhanced mammography. There are several indications in the US. Some are FDA approved, that's our Food and Drug Administration, and some are not. For the most part, in symptomatic patients or diagnostic examinations, it is approved. So it's approved for the evaluation of symptomatic patients. It's approved for extent of disease in those that have known breast malignancy, where we want to find out the extent of disease prior to initiating therapy. We also It is also approved in the evaluation for response to neoadjuvant systemic therapy. So there are certain patients that have breast cancer that start neoadjuvant therapy prior to breast surgery or definitive surgical therapy. These patients, we like to image before and after therapy. The next subset of patients are abnormal mammographic findings identified at screening. So we call these callbacks. And then there are other indications which are not FDA approved here in the United States, but have been shown to be useful. And this is for supplemental screening for high-risk patients. We have a large population of high-risk patients at our institution, and we do utilize this for screening those patients who have a contraindication to MRI. Additionally, there have been patients that have used contrast-enhanced mammography as a supplemental screening tool for intermediate risk patients and dense breast, even though this is not FDA approved. So diagnostic imaging in the symptomatic patient. We have found that contrast-enhanced mammography does demonstrate a higher sensitivity and specificity for the detection of malignancy in symptomatic patients when compared to mammography. Tennant et al. Showed that there was an improved sensitivity of 95 versus 84% when compared to the low energy images alone, which is the same as plain mammography. And the specificity was improved at 81 versus 63%. Another study compared contrast-enhanced mammography to ultrasound and to mammography and showed a higher sensitivity for detection of breast cancer in symptomatic patients with contrast-enhanced mammography, 100% versus 90% for mammography and 92% for ultrasound. Additionally, showed increased accuracy, 78% for contrast mammography, 69% for mammography, and 70% for ultrasound. Again, for detection of malignancy in symptomatic patients. Here's an example of a diagnostic examination we did for a symptomatic patient. This patient was referred to us specifically for contrast mammography, and she had a palpable abnormality in her left breast. She was a 57-year-old woman that with a remote history of a left retroareolar abscess for which she had surgical excision. The outside institution was unsure if this abnormality behind her nipple was secondary to malignancy or post-surgical change. We did a contrast-enhanced mammogram, and here are the low-energy images. Here on the right is on the left is the CC view. You can see a focal asymmetry or even an irregular mass in the subareolar breast, and you can also see this morphologically abnormal lymph node in the axilla. The recombined images demonstrate an irregular enhancing mass with indistinct margins here, which is consistent with malignancy. And you can also see that she has multifocal disease. She has quite a few other little additional areas of enhancement. And this enhancement in the morphologically abnormal lymph node is also noted. Extent of disease is another reason why we do contrast-enhanced mammography. And it has shown a slightly decreased sensitivity when compared to MRI in a couple of studies here. When I say slightly, pretty small, 94 to 96% versus 96 to 99% for MRI. But also contrast-enhanced mammography did show a significantly higher positive predictive value than MRI, 93 to 97% versus 60 to 85%. And furthermore, contrast-enhanced mammography had fewer false positive findings. Approximately 6 to 9 times more false positives were identified on MRI examinations than contrast-enhanced mammography. Here is an example of a patient that we imaged with contrast mammography for extent of disease. This was a 58-year-old woman. She had biopsy-proven multicentric invasive ductal carcinoma. This Both areas had tubular features and were grade 1 in the 5 o'clock and the 8 o'clock right breast. And our breast surgeons here like to try to do breast conserving therapy if possible, and we're concerned that maybe she could have that if these were the only 2 areas of disease in her breast. Since they were so low grade, even though they were far away, they could do 2 lumpectomies. She was unable to have MRI, so we did a contrast enhanced mammogram. And here you can see on the right CC view, you see 2 spiculated masses. Both have biopsy markers. And on our contrast enhanced recombined images, you can see that the masses enhance appropriately as you would expect for invasive ductal carcinoma with the associated biopsy markers, but there's no additional enhancement in these areas, and she was able to undergo breast conservation therapy. Response to neoadjuvant systemic therapy. Contrast enhanced mammography has been shown to be comparable to MRI in this respect. One example, Patel et al. Compared contrast enhanced mammography to MRI for residual malignancy after completion of neoadjuvant systemic therapy, and showed very similar sensitivity, specificity, positive predictive value, and negative predictive value. You can see those numbers here. Here is an example of a case that we performed for response to neoadjuvant systemic therapy. This was a 77-year-old woman with invasive lobular carcinoma. And you can see here that A and B are the pre-neoadjuvant systemic therapy images, and C and D are post-neoadjuvant systemic therapy. And this is an invasive lobular. Here you can see the irregular mass with indistinct margins with associated biopsy marker. And on the recombined images, you can see that there is subtle enhancement of the invasive lobular carcinoma. This patient also did have subtle enhancement in the subareolar region and out here laterally in the breast, which was noted to not be malignant on biopsy. She underwent neoadjuvant systemic therapy, and you can see she had a very favorable response in her invasive lobular carcinoma without any residual enhancement identified. Here's another example with A and B being the pre-neoadjuvant systemic therapy and C and D being the post, and this patient had a very good response to therapy. Diagnostic imaging, abnormal mammogram is another reason for contrast enhanced mammography. So if they have an abnormal screening mammogram, contrast enhanced mammography can be utilized to help identify if there's anything abnormal. In this particular case, this was a 50-year-old woman who did have a strong family history of breast cancer, but was unable to undergo MRI. She had a screening mammogram in combination with a contrast enhanced mammogram because of this high risk. And you can see here, she has this oval mass. If we had the right MLO view in addition to this right CC view, we could confirm this was an oval mass. It has circumscribed margins, looks benign, but we would normally have to do additional views in ultrasound to fully work this up and make sure it was nothing to be concerned about. However, with contrast enhanced mammography and the recombined images, you can see here there's no enhancement. This is nothing to worry about, and we can obviate the need for further diagnostic imaging. Other indications which contrast enhanced mammography may be utilized more highly in the future or high-risk patients currently here in the United States for patients that are considered high risk with genetic mutations with lifetime risk greater than 20 to 25% or history of chest radiation. MRI is currently recommended as a supplemental screening tool. But as we have shown here, contrast enhanced mammography does demonstrate similar sensitivity. So it should be and may be considered as a supplemental screening tool in the future. Currently, for our patients that do not have the ability to undergo MRI for certain reasons, do get contrast enhanced mammography in replacement of that. Another group of patients to consider are women with intermediate lifetime risk and those with dense breast tissue. There have been some studies out there that have shown that there's improved cancer diagnosis with contrast enhanced mammography when compared to mammography alone in patients with dense breast. In this particular study that was done in 2014, you can see that the numbers are quite impressive, a 21.2% increase in sensitivity, a 16.1% increase in specificity, and a 19.8% increase in accuracy. Leads us to our third question. So when compared to MRI, contrast enhanced mammography, A, demonstrates a similar sensitivity for detection of breast cancer. B, demonstrates a decreased specificity for detection of breast cancer. Or C, is more expensive than MRI. And the answer is A, demonstrates a similar sensitivity for detection of breast cancer. So now we're going to talk about some image interpretation. First, when we're looking at contrast enhanced examination similar to that of MRI, there is background parenchymal enhancement that has been observed. And background parenchymal enhancement is usually symmetric and it's normal after contrast administration. It fluctuates with hormone levels. And background parenchymal enhancement has been classified under MRI examination. And for contrast enhanced mammography in 4 categories: minimal, mild, marked, and moderate and marked. And you can see examples of those here. And there have been studies that have associated the amount of background parenchymal enhancement on MR with the likelihood for developing breast cancer. These studies have not yet been done with contrast enhanced mammography, but there has been, they have shown that there seems to be a similar amount of background enhancement when comparing contrast mammography to MRI. So there is probably a correlate there. And they have done studies where there's substantial agreement that demonstrate background parenchymal enhancement detected on contrast enhanced mammography and MRI images. We'll talk about some benign enhancing anatomy and lesions. Here is just a right CC view. And this is just to show you that the nipple enhances here on our recombined images. You can see that nipple appears bright as it didn't before. And that is normal for contrast enhanced mammography. Nipples also enhance typically symmetrically on MRI examinations. So that's something to be aware of. Again, this same image of this right CC view also shows a common benign entity that we see, which is a lymph node, this reniform shaped mass here. You can see these oval circumscribed masses here. And when we do these recombined images, those subtract out, those are benign. And this lymph node, although benign, does enhance as we would expect, and it similarly would enhance on MRI as well. Skin lesions can enhance on contrast mammography. Here we see a 49-year-old woman that has type 1 neurofibromatosis, and she has multiple neurofibromas around her nipple, and you can see these masses here on the low energy images in addition to her nipple. And when we do the recombined images, you can see that these lesions do enhance, and that is normal for this type of lesion. Here on the right of the screen, you see this oval mass here, circumscribed oval mass. On the low on the recombined image, as you can see that this area does enhance, this oval mass enhances. When going back on her prior imaging, we noted that this was an area where a mole marker was placed. This is a mole, and moles do enhance as well. Fat necrosis, the great mimicker, can also enhance, and it will enhance on contrast enhanced mammography as well. Here we have a 67-year-old woman. She has a history of invasive lobular carcinoma, status post breast conserving therapy. Because she had dense breast tissue, we would normally do annual MRI examination, but she is unable to undergo MRI. So we are doing annual contrast enhanced mammography. And you can see here on the recombined images in her lumpectomy bed, she has this nice, smoothly demarcated area of fat necrosis around her lumpectomy bed, which is benign. Cysts in the breast have a unique appearance on contrast enhanced mammography. They actually have no enhancement and appear to have a negative enhancement. You can see here on this left CC view on this left MLO view, there is an oval mass here, and you may make out some asymmetries here. We do the recombined imaging, and you can see that there's actually a negative contrast effect where these cysts are, because there's no normal breast parenchyma, just fluid in that area to take up the contrast. Here is an example of a fibroadenoma. This was a long-standing fibroadenoma in a patient that underwent contrast enhanced mammography, and they also can enhance similar to MRI. We'll talk about some malignant lesions now. Ductal carcinoma in situ. This is an example of a 60-year-old woman that had biopsy-proven ductal carcinoma in situ, undergoing evaluation for extent of disease. You can see here in the lateral left CC image, there are fine pleomorphic calcifications and a segmental distribution demarcated by the blue arrow. On the recombined image, you can see there is significant enhancement, non-mass enhancement, and a segmental distribution associated with the pleomorphic calcifications extending slightly beyond the area of calcifications, demarcating the area of disease. And you can see that the rest of the breast is very quiet. And however, she did end up going to mastectomy because of the extent of disease in the lateral breast. Here is an example of invasive ductal carcinoma. This was a 41-year-old woman who underwent contrast enhanced mammography for extent of disease. Typically, if a patient is diagnosed under the age of 50 or has dense breast tissue at diagnosis, we will do an MRI examination. If they cannot undergo MRI, we will do contrast enhanced mammography, and that's what we did here. You can see here demarcated by the blue arrow, this partially obscured oval mass in the lateral aspect of the breast on this right CC view. Very difficult to see the margins here due to the dense breast tissue. However, the recombined images demonstrate this mass nicely. You see a portion of the mass, the necrotic center, and some associated non-mass enhancement extending anteriorly. You can also see that the additional portions of the breast are without evidence of disease. This patient was able to undergo breast conservation therapy. Here's an example of invasive lobular carcinoma, the second most common type of breast cancer, following invasive ductal carcinoma. This is a unifocal invasive lobular in a 75-year-old woman that underwent contrast enhanced mammography for extent of disease given her pathology of invasive lobular carcinoma and her dense breast tissue. You can see here demarcated by the arrow, partially obscured mass with a biopsy marker. Hard to tell if there's additional disease, but following the administration of contrast, we can see on these recombined images, you can see this irregular mass with indistinct margins, demonstrating mild enhancement, and the remainder of the breast is silent, and this patient was able to undergo breast conserving therapy. One thing to note that invasive lobular, as opposed to that invasive ductal that we saw earlier, sometimes has a tendency to enhance less avidly on contrast MRI, on contrast enhanced examinations, including contrast mammo and MRI. So that's something to be aware of when you're interpreting these images. Here is an example of a multifocal invasive lobular carcinoma. This was a 78-year-old woman that had this oval mass, which you can see here projected on the right MLO view. We have a SAVI marker in this mass, planning on breast conservation therapy. She had dense breast, was unable to undergo MRI examination, so we did contrast enhanced mammography. And unfortunately, in addition to the biopsy-proven malignancy, she also had extensive disease extending over 6 centimeters and involving at least 2 quadrants, and she was unable to undergo breast conservation therapy. A couple of potential pitfalls and diagnostic challenges or interesting cases. This is a case of free silicone. We typically, in patients that have free silicone, will do MRI examinations, and sometimes they are unable to undergo MRI, so we do contrast enhanced mammography. This is a 60-year-old patient who is at elevated risk for development of breast cancer due to family history. She had a history of implant rupture and subsequent implant removal, but still has a fair amount of silicone within the breast tissue. So we did a contrast enhanced mammogram, and you can see here that the silicone subtracts out, and we can see the rest of the breast tissue fairly well to evaluate for malignancy in this patient. This was an interesting case and a potential pitfall of small tumor size. This was a 64-year-old woman who came in for a callback from screening and underwent ultrasound examination. Incidentally, under ultrasound, we found a 4-millimeter invasive ductal carcinoma, which was biopsied. The area that originally was of concern turned out to be nothing to worry about. So following the biopsy here, you can see this heart-shaped marker was placed in the region of tumor. She underwent contrast enhanced mammography to evaluate for extent of disease. And on her recombined images, you can see here the artifact from the clip, but there is absolutely no enhancement in that area. So it's important to know that small tumors and some histologic low-grade tumors and DCIS can sometimes give a false negative result, either due to minimal enhancement or abrupt washout. Here is another potential pitfall. This is a 38-year-old woman that had a DCIS and underwent contrast enhanced mammography for extent of disease due to her young age and her breast density. You can see here she has multiple clips circled here. This is kind of her extent of calcifications, which probably are not projecting very well, but this is where her disease was. We wanted to image to see if there's any more disease, and you can see the subtle non-mass enhancement as you would expect for DCIS in this patient, localized to the area of concern. But you can also see she has this rim artifact around the rest of her breast, which is pronounced in this particular image. And you can see that sometimes that could potentially obscure or limit evaluation for subtle enhancement. This is related to scatter, and we'll talk about that in our artifact section in a minute. Another pitfall in this case, this was a case where on the left, you can see her year prior. This is a right CC mammogram that was negative, and she came back for her annual screen the following year, and there was this new developing asymmetry here in the medial posterior breast. In order to evaluate this asymmetry more, we did contrast enhanced mammography, and this area did demonstrate mild enhancement in this new area. So this developing asymmetry was given a BI-RADS category 4 and was biopsied based on landmarks and came back to be PASH. So we probably biopsy this again, but PASH is a potential pitfall. This is one of our challenging cases. This patient is a 73-year-old woman. She has biopsy-proven malignancy in the 9 o'clock breast and the 2 o'clock breast. You can see these masses here, biopsy clips here with irregular masses. Additionally, she also has numerous masses in both breasts that have been fairly stable for a number of years. This woman has papillomas, papillomatosis, and you can see here, even on contrast enhanced mammography, these papillomas also do enhance, similar to that of the invasive malignancy. Sometimes for these patients with multiple papillomas, we try to follow them with MRI if we can, or contrast enhanced mammo, but they are very challenging cases. So question 4, true or false? Low-grade DCIS and small invasive malignancies may fail to demonstrate enhancement on contrast enhanced mammography and MRI. It's true. So our last section, we'll just talk about a couple of artifacts here that we can come across on contrast enhanced mammography that we need to be aware of, so where our interpretations are not limited. Ripple artifact is one that we commonly see, and this is related to motion. Basically, you can see these kind of parallel black and white lines on the recombined images here, denoted by the purple arrows. And it's more commonly seen on the MLO views, where there tends to be more motion. It can be sometimes called a crinkled or corrugated appearance. You can see here, this is the same patient with 2 different images of the breast, one without the artifact and one with the artifact and one without the artifact. And you can see the interpretation of what's going on is much easier without this artifact. So basically, to control this, you really want to just decrease the patient motion. One way to decrease patient motion is to decrease patient anxiety. Also, there have been some places that have recommended doing the MLO views first to decrease patient motion because they tend to have more motion on those views. Contamination. This is another artifact that you may run across when contrast spills out onto the skin or anywhere, and it is detected on the recombined images. You can see here, they can appear as these pseudo calcifications. On this image here, you can see some directly on the skin. Sometimes it's in a non-anatomic distribution, so you know what it is, but occasionally it can be a little tricky to figure out. So it's important to be aware of this artifact. Modifications to carefully control and avoid contrast spillage. If you see it on the image and you're there with the patient, you can try to clean the skin and repeat if you can get it done in that 10-minute window. Otherwise, you can call them back and repeat the imaging if necessary. We actually had some difficulty and some troubleshooting with this. There was a time when we had about 6 patients in a row that had this skin contamination. And what we realized is that the technologists actually needed to change their gloves. So we were injecting the contrast. The technologist was unhooking the catheter from the power injector with this with a pair of gloves on, and then she was taking the patient and positioning the patient for the images with that same pair of gloves on. So now what we do is they disconnect the catheter, the IV power injector with one pair of gloves, change gloves, and then go and position the patient. Persistent intravascular contrast. Here is an example of that. You can see here on the right image, there is a contrast retained in that vessel on the recombined image. And sometimes patients do have slow flow through the vasculature. And this appearance should not limit interpretation too much, but there are modifications that you can do. And one is really to not compress the breast until after that 2-minute mark. So you want to inject the contrast, allow the contrast to get into the tissues and out of the vasculature, and then at 2 minutes, compress the breast for that first image acquisition. And lastly is that rim artifact, which we saw in that case of DCIS a little bit earlier. And this is from the radiation scatter from the different density within the breast. Here it has a C-shaped appearance on the CC view. And you can see that it is really just at that interface between the glandular tissue and the pre-mammary fat. They've done equipment upgrades that help reduce this artifact, but if you can't get an equipment upgrade, they have shown that really this artifact does not limit interpretation too much if the upgrade is not possible. Conclusions. Contrast enhanced mammography is a relatively inexpensive and quick examination with a similar sensitivity to MRI for the detection of breast cancer. It has several indications for use and potential indications for use. It's important to understand that there are benign enhancing masses to lead to enhance interpretation. And also knowledge of common artifacts is important for adequate interpretation. Thank you all very much for your attention, and I'm open to any questions.
All right, we have one question in the Q&A box. It is about the relationship with contrast mammography and BI-RADS. It says, will contrast enhanced mammograms revise BI-RADS?
I think probably in the next BI-RADS there will be possibly a section with regards to you know, the BI-RADS appropriate terminology and criteria for contrast enhanced mammography. I think that will come about. There are some papers out there in the literature that are starting to try to come up with BI-RADS appropriate terms.
Right. And they're also asking if you can re-explain the technical portion of how the contrast mammography is done.
So basically it's subtraction mammography. So you take two images of the breast in the same compression. One is it's a standard full field digital mammography or mammogram. And then the second is with the copper filter and is optimized for the K edge of iodine. And then you subtract those two images. So that first image is a low energy image, and the second energy is a high energy image, and you subtract those and you get the recombined images.
And it seems those were all of the questions that we had. It's a very interesting topic that has a lot of potential, and thank you so much, Dr. Zamora, for going over all the technical part and all the ways that it can be implemented in practice. I think it's certainly something that we're going to keep hearing about, and it's going to keep growing. And as you were saying, hopefully at some point we'll see it in violence too.
Yeah.
So I think that with this, we conclude our session for the day. Thanks everyone for joining. Thank you all so much. And thanks to Dr. Zamora for her amazing lecture.
Thank you. Thank you for having me.
Thank you so much for the fantastic lecture. It was highly educational. All the lectures are recorded and everyone can watch them on our YouTube channel or on Health for the World Academy. Thank you so much again. Hopefully we'll see everyone in the future, and have a nice day.
Thank you.